needle. Okay, so we can always have a panoramic view of the middle ear. So this is the mesotympanum from the facial nerve. We can see this is a processus cochleariformis with a tendon of tensor tympani going anteriorly. This is the muscle of tensor tympani, you see here. And then inferior to the muscle of tensor tympani, we can see the eustachian tube. So even with a flap inside you can see it clearly. I am still using the 0 degree, but we can see the hypotympanic air cells. This is the cochlea and promontory. And you can see the inferior canaliculus give rise to a Jacobson nerve up to the superior canaliculus. And also pointed towards the processus cochleariformis. It gives the landmark for the facial nerve. And you can see the facial nerve is above and partially covered by the processus cochleariformis. So this is the tympanic portion of the facial nerve. And this is almost the end, and it turns deep into the IAM. So this is the geniculate ganglion. This is the stapes superstructure. And this is the stapedius tendon. And you can see a mobile foot plate here. And then this is the pyramids. Between the pyramids, then you can see this is the ponticulus and suction. Okay. This will be clearer. You see the round window niche here. So this is the subiculum. Well, between the ponticulus and the subiculum, you can see the sinus tympani. And you will be able to see the fustus here. Okay, there's a bony niche we call fustus. The fustus is always pointing towards the round window. So this is the round window, and this is the sinus subtympanicus. This is the funiculus, and this is the hypotympanic air cells. So you can see beautifully at a panoramic view of the middle ear. So we can also examine whether there is a cholesteatoma surround, and this is the anterior limb of the lateral semicircular canal. So I think this is almost the limit for the complete endoscopic mastoid surgery. If it extended more posteriorly, you need a lot of bone drilling involving the posterior canal, and your meatus may not be big enough. But we can always, like in this case, we perform a cortical mastoidectomy, and we can combine it with endoscope and microscope. So after doing the cortical mastoidectomy, you already see the facial nerve. You go to the antrum, and then you will clear the disease in the mastoid down to the mastoid tip. So you can always do a canal wall up with this and checking with the endoscope. So even you use a microscope, you can always do the checking. So through this, we can see the superior medullary ligament beautifully hang up to the top. And also you can see this is the tensor fold. You right? I show you this is the tensor fold. So this is tensor fold that's opened. This is the tensor fold. You can do it trans canal to check the tensor fold. Like this. Okay, so this is there's the supratubular recess, the areas that may be hidden the cholesteatoma, and you can always check with the endoscope. Right. So afterwards, I would switch the microscope to continue our dissection. So some of us will have examination with temporal bone examination, or some of you during the operations, you might be doing a revision operation, and you might be receiving some others previous dissection, like from this. So you always identify yourself with your landmarks. So this is what you can see, the posterior canal wall, and this is the mastoid tip. Okay, you go for the outermost section. So during your break, I did a little bit of on the temporal bone. So faster our dissection and demonstration. So this is the tegment that I can identify. This is the sigmoid sinus. This is the facial nerve. This is the posterior canal wall. So this is the mastoid tip. So I know my orientation is right. And before you zoom in. Now there are two questions that I will demonstrate and answer you live. And number one is, how is the facial nerve relationship with the digastric ridge? So the digastric ridge, usually find it in the mastoid tip right here. So you can see this is the mastoid tip, and this is the sigmoid sinus. And now you can see this is the pinkish area, and I'll zoom in a little bit more. So now if I drill more over here, then you can see already the muscle. Yeah. So this is the digastric ridge, and with that you can actually remove the bony tip. Okay, so this is the direction of the digastric ridge. Now, how do we use that as a landmark for the facial nerve? Now we can see this is where we see the lateral semicircular canal, and the facial nerve is related to, next to, and slightly deep to the dome of the lateral canal. And maybe you will see the short process of incus, which we have already removed. And you may be able to see the chorda tympani. This is one of the landmarks. And basically, if you can find the digastric ridge here, and you can find the short process of the incus and the lateral semicircular canal. Here, it marks the second turn of the facial nerve. Then you draw a line, and basically you can imagine the facial nerve is here. So if you continue to do the dissection, then you will be delineate the whole cross of the facial nerve. So I'm now using a diamond burr. So you have to familiarize yourself with your burrs. So you will choose the biggest possible burr that is working good for you. If you need to do a lot of cutting action, then you use a cutting burr and you cut it by the side. If you are working like me to a very important structures that you don't want to cut your facial nerve, and then you have to use it, or you have to do it end on, then we use the diamond burr. With the diamond burr, it creates a lot of heat. So we use a lot of irrigation. So you can see we use a lot of irrigation. And your motion is like a shroud along the facial nerve. You don't want to cut the facial nerve like this, but you want to dissect it out. So you want to find the facial nerve, and then the action would be slow and gentle. And when you see the facial nerve, then you don't want to injure the facial nerve. So this is how you do it slowly, and then we can find the whole course of the facial nerve. All right, you can barely see the pinkish color. And usually, unless you want to decompress or unless you want to translocate the facial nerve, either you can do it anterior translocation or posterior translocation. For exposure, then you have to remove very gently from the bony prominence. But for exposure, I think this is quite enough. But if somebody asks, how do you, if there is a cholesteatoma here, how do you remove the cholesteatoma from a dehiscent facial nerve? Of course, we do it very, very gently. And then, so you already see the facial nerve here. Then we might use a non-traumatic. We have to look at it clearly. Okay, and you can use either a non-traumatic instruments, a smaller suction, and then you gently peel it off. So you peel on the same direction. So if, for example, if you already have a dehiscent facial nerve here, and then you want to remove it, then you gently peel it off, gently along the fiber, just like this, gently peel it off. Use your suction, both hands, gently peel it off. So there's no problem on the facial nerve. It's quite tough. So you just identify it and protect it, don't cut it. All right, just peel it off like this. So if you are experiencing a dehiscent lateral semicircular canal, I can blue line that later on and show you how. Another question from the audience is, how do you thin down but not injuring the posterior canal wall? So the thing is, number one, you use the biggest possible burr, and the bigger the better, and use a diamond burr, it won't cut. And then you really saucerizing it to make it really, really, really thin like this. And it should be even. So this is too thin, this is too thick, then it's not even. And you try to make it evenly thin. And then you will slowly try to gently decompress like this. It's not only working for the posterior canal wall, so you make it really even and push it. This technique can be also performed through the in the sigmoid sinus. So you can see this is the sigmoid sinus, and I want to approach to the IAM, and this is blocking my way. You can see this sigmoid is blocking my way, blocking my burr. So I have to decompress the sigmoid sinus. So I will make a Bill's island. So this is the bone that I want to remove. And then I don't only remove one single spot. If you only remove one single spot, then you will puncture a hole. So you polish all the way, polish until really, really thin. Behind it, polish really, really thin, leaving one single island of bone here, and then you gently compress on it. Okay, here is on our way. Okay, so now we can gently pushing it. All right, so this is what we call a Bill's island. So we're gently decompressing the sigmoid sinus without injuring it. All right, and then you polish the rest of the edges of the bone. You don't want them to hinder and puncture into the sigmoid sinus to test if it's on both. No, you don't want that. So then we can gently push it all the way down, and it will expose the posterior cranial fossa bone. While we remove the bone, then we can approach to the posterior cranial fossa dura. So I do some bone drilling to expose the labyrinth for us. So this is the lateral semicircular canal. This is the posterior semicircular canal, and this is the superior semicircular canal. You can see this is the tegment with a bone covering. So the tegment is actually lower than the dome of superior semicircular canal. So you don't want to breach the dura in order to find your superior semicircular canal. You just want to show the canal. And then you can draw a Donaldson line. So you draw Donaldson lines along the lateral canal. And then just inferior to it should be the endolymphatic sac. Let's see if it's true or not. So we drew all the drilling, more drilling on the posterior cranial fossa. So we want to expose the dura. Actually, the endolymphatic sac and endolymphatic sac is sitting between the bone and the dura. So it's impossible for you to find it with the bone intact, but you want to thin down the bone as much as possible. And then, so this technique applies to everywhere, important structure. So you thin it down horizontal and smoothen it. You don't want to just puncture a hole. If you polish it well enough, they will thin as if a paper. And you see, already we can see the endolymphatic duct and endolymphatic sac from here. Yeah, so it's very obvious now. Is it obvious now? Yeah. So you can see it goes all the way. It follows the Donaldson line. It obeys the law. And if you want to do the decompression and the lymphatic sac decompression, you do have to expose it and you do have to open it. And if you're not convinced, sometimes if you're not convinced, or they got bills. Okay, so still we have some bones. Okay, we do still want to remove some more bone. Don't worry about that. The dura is actually quite tough. All right. Okay. So this should be the way. So you remove the bone, but keeping all the dura intact, and then you try to separate the endolymphatic sac from the dura. So underneath is the dura. You can remove the bone, the thin bone like this. Then you will be showing to your examiner. Now I can find my endolymphatic sac like this. The dura is down and then the lymphatic sac is up. Okay, and you can try to open it with a knife or needle. Both are fine. You can zoom it in. A sharp dissection. Okay, you can show to your examiner, and this is a sac inside. So there are two layers. Some people will put in shunt and some people won't. So it depends on what you believe. So this is the endolymphatic sac and then endolymphatic duct. But unfortunately, if you want to go to the IAM, you have to cut it off. So before we cut it off, we can appreciate its relationship with the labyrinth. Then when you want to dissect, if you want to dissect the labyrinth, now you want to blue line it. So still you're using a diamond burr. So when you burr, always burr on the direction that you want. So the direction of the lateral canal, you can already see the blue line of the lateral canal. Be careful that you don't injure the facial nerve. So you can see the relationship of the bony labyrinth and the membranous labyrinth. You see the lateral canals here. Then we can do the same on the posterior canal. Say, 我要個4mm 嘅 cut diamond。Okay, I'll zoom in a little bit to show you. Right. So you can see it's called blue line because we did not open it, but we can see through it. So the superior canal. Okay. So this is the dura, the middle cranial fossa dura. The superior canal is going up to the middle cranial fossa. So you can, in a CT scan, you may see the arcuate eminence, or in a middle cranial fossa approach, you will see the arcuate eminence. It's okay to remove some of the bony labyrinth on. If you know the blue line, then you know the anatomy of the lateral canal, the posterior canal, and now we are trying to blue line the superior canal. Now you can see this white dot is the subarcuate artery. So this is marking the center of your superior canal. You continue to blue line the posterior canal, and we might be able to see the common crus joining the posterior canal and the superior canal. So, okay, let's go. You will gently do like a circular movement to delineate the superior canal. And usually for superior canal, the anterior limb is more lateral than the posterior limb. Right, we're almost seeing it. See, you see the blue line? Yeah, you see the blue line of the superior canal. So try to practice this during your lab dissection in your own country, and you will appreciate how beautifully they connected with each other. So this is the labyrinth, and the superior canal. The superior canal's ampullus is right here. Posteriorly, it connected with the posterior canal with the common crus right here. The lateral canal, the ampulla is right here. So even we can go more anteriorly. Now we're going to open the canal. So to blue line it, I use a diamond burr, but in order to open it, and we can keep going faster, then we can use the diamond burr. Now you see the relationship with the labyrinth, membranous labyrinth with the endolymphatic sac. Right, then we can open it here. We'll show you. That's American. Oh. So this anterior ampulla, marks the superior end of the internal acoustic meatus. And so the ampulla of the posterior canal actually at the inferior rim. So if we follow this, so this is the posterior limb of the ampulla of the posterior canal. But be very careful that it's actually sitting medial to the facial nerve, that you don't want to cut the facial nerve. So that's why you have to identify the facial nerve. So after this is your landmark, the superior ampulla. This is ampulla. So here, all the bones they have to go. Here to the tegmen, all the bones that have to go. Here from the inferior ampulla to the jugular bone, all these bones have to go in order to expose the IAM. So this is your landmark. For the approach to the internal acoustic meatus. And unfortunately, we have to remove the endolymphatic sac before we can approach it. So now we open the posterior canal, and then we open the homunculus, and then we open the superior canal. So now you can see the utricle. And also the lateral canal, we open it. Okay, endoscope. Okay, now we switch to the endoscope to appreciate the anatomy of the labyrinth. So this is where we are with the microscope. So this is the endolymphatic sac. This is the facial nerve, still intact. We open the posterior canal, the superior canal, and the lateral canal. Now we can look into, so you can see the dark cell inside the utricle. So this is your utricle, and more deep inside is the saccule. Well, the saccule is in connection and in close relationship with this stapes. You got needle. Well, now we remove the ink stapes. Stapes here, marked it. And then you can see also the dark cell from the canal. All right, so they are connecting. So you can imagine a better three-dimensional imagination of the labyrinth system with the cochlea here. There's a cochlea here, facial nerve here, superior canal, lateral canal, posterior canal, the utricle, and the saccule. Okay, so this is the facial nerve. Along the modiolus, this is the cochlea. So this is the opening of the cochlea. Around here is the end of the superior vestibular nerve. So around here is the end of inferior vestibular nerve. So in your mind, if you join these together, then you will be find the opening of the IM just facing you right here. So I don't think how much time that we have. Okay. Okay. So for the interest of time, we'll put it in contact. I have prepared another specimen.
In contact.
In contact. Okay. So I want to show you this. This is some pre-drilling transcanal approach to the IAM. So we do not have a post-auricular incision, but we have the transcanal incision. Just through this transcanal incision, we can actually expose everything. So what I have prepared for you, and while Professor Tong is drilling, is the transcanal anatomy of the everything that you have seen and you'll be seeing, because the approach is quite different. If you look at it like post-auricular approach, the angle is around 30 to 45 degrees. So what you see is like this. But if you head on, so the facial nerve is a little bit different, but still you can find all the landmarks that you want. So this is the hand of malleus. I do a wide opening of the ear canal. So this is the hand of malleus. This is the chorda tympani. So you can appreciate the relationship between the chorda tympani and the ossicles. So it gives rise from the facial nerve all the way through the caudal ridge. So you can see this ridge. This is ridge we call a caudal ridge. So it goes through posterior canaliculus between the incus and the malleus. So it's underneath the malleus, go to anterior superiorly to the canal of Husha, right here. It exits the middle ear via this canal of Husha. And you can see this is the hand of malleus and the long process of incus into those stapedial joints. This is the stapes with the tendon, stapedius tendon. So in this, you have a very deep, so this is very beautifully the ponticulus, the subiculum. So this is the sinus tympani. This sinus tympani goes underneath the facial nerve. That this is a type C sinus tympani. So this type C sinus tympani might not be easily remove the carcinoma from type C. You might need to go via a post-auricular approach or a posterior tympanotomy. So this is the fustus pointing to the round window. So this is the cochlea, and this is the Jacobson nerve and the canal. And you can see this is the jugular bulb. So this is not highlighting because I do all the drilling. This is a jugular to prove. So I actually do some pre-drilling. So this is the jugular. And this is the eustachian tube. This is the tensor tympani muscle. So, tensor tympani muscle runs superior to the eustachian tube. to prove. Yeah, we can remove it and you see the muscle fibers here. And then how the internal carotid in relationship with the eustachian tube. So now this is the carotids. Okay, pose. Okay, so this is the internal carotid artery. And in relationship to the cochlea, here is the cochlea. So if you use if you have a lesion in the pitch's apex, which is inferiorly situated, like the cholesterol granuloma that you might want to drain, you can keep we can approach it via the infracochlear approach. So the landmark for the infracochlear approach would be the cochlea. So it's underneath the cochlea. Superior border is the cochlea. Anterior border is the internal carotid artery. Inferior border is the jugular bulb. And then you see this is the air cell. You can do the drilling. And then you can then now open. Oh, I'm sorry. Okay, now we are drilling under the water technique. So you need a quite lot of irrigation section. Huh? Okay. Now you can now drain the pitch's cell by this. So it's okay for you to take a biopsy to drain the cholesterol granuloma via this approach. All right. See? So this is the pitch's air cell. You can open it a little bit more via this approach. Yeah, see? All right. So this is the pitch's air cell that we have drained. So we keep the cochlea intact and keep everything intact. And this is the infracochlear approach. Now I would like to remove the oxicles by this juncture. Divide the inside joint. Remove the incus. All right. Okay, so anyway, we have to remove the chorda tympani in order to demonstrate to you the anatomy. But if you want to remove the caudal ridge, you can remove like this. But scissors, okay. But we need to scissors. Remove to anyways, we remove everything to demonstrate how is the facial nerve and everything. Well, okay. Right, cue it. So now I remove the processus cochleariformis, the bony portion. And sometimes this is when you have to plug the eustachian tube and you have already removed everything. This is quite a nice flap, a muscle flap for you to plug the eustachian tube. This vascular flap, right? So after removing this, the bone, we can see the facial nerve. And with this, we might be able to find the GSPM. The The GSPN is the first branch of the facial nerve, runs anteriorly, superiorly to the middle cranial fossa and form the median nerve. Okay, so you see this is the bush crocodile. Views. Okay, so this is the stapes. This is the facial nerve, the tympanic portion of facial nerve. And this is the GSPN. It's thicker than you imagine. It gives a turns here. Actually, it goes into the IAM. Okay. So you may see it turns into the IAM here. So usually if we do the decompression, we just open this, it's done. But I want to show you how it enters the IAM. So here. So it enters the IAM here, right? You see? And then it goes the branch to the GSPN more anteriorly. And trace all the way. This is the GSPN. This is the turn. See? Okay. So then we remove also the stapes wall. Seems that the foot plate is fixed. Ooh. Okay. So now we can also show you the cochlea. We open the cochlea and you will see the anatomy of the cochlea. We can do it with a microscope.
Okay.
All right, so we're actually seeing the same thing with a microscope if you're wide open. And so this is microscope. This is the facial nerve, the horizontal. So this is tympanic portions, and this is the mastoid portions that we can do a little bit more. I want to open the cochlea for you. So this is the facial turn, or the window side again. 要個 endo. So you can see this is the membrane, and this is the basal turn and the second turn. So if you use the endoscope with a good magnifications,
轉鏡
and you can see the basal turn, the second turn is here. So when we open it, section. We find so now you can look inside the cochlea. You can see the hair cell. You can magnify it. And then we focus on it. See? Very beautifully the hair cells. You can even appreciate the hair cells inside the cochlea with an endoscope. So needle. You can possibly see the scala tympani. So this is the temporal membrane, and beneath is the vestibuli. All right. This is the vestibuli. This is the tympani, and you can see the hair cells here. Okay. So this is the second turn. To prove this is the second term. All right. So, and you appreciate the relationship between the stapes. So this is really have the otosclerosis. Interesting. Okay. So stapes foot plates section. Okay. Then you go inside, you can see the hair cell as well. So you can also see the impingement, the impression of the superior vestibular nerve. So this is almost the superior vestibular nerve. So how this is the axis, the modiolus of the cochlear nerve. This is the entrance of the facial nerve. This is the superior vestibular nerve. So with this, we can just open into the IAM right here. So I think by now we should have a better understanding on all the anatomy of the facial of the middle ear, the cochlea, the facial nerve, the internal carotid artery, the jugular bulb, so the facial nerve again, and then the mastoid ear cell right here. So this is all we can see transcanal. How much time do we have, or do we still want to open it? I think it's 12 o'clock now, and I think it's the time for time's up for the section for today. And so hopefully you can get some basic idea. Number one, how we can use the microscope and endoscope together, and how the anatomy of the middle ear, the facial nerve, the inner ear, the vestibules, and you take much more time when you go in the IAM. So if you have a hands-on later on, to join us, because we will have more times, and you have hands-ons that we can appreciate more anatomy on your own, and you can have various approach. You are the surgeons of your patients and not your for you. You can see us. We are reaching around, and sometimes you want